Thanks very much. Good evening, everyone. Good morning from Glasgow. It's 8 a.m. here, and really appreciate you joining to share this presentation this morning. I know it's a little bit later in the afternoon for some of you. So I'm going to dive right in and talk about various aspects of CDH, but also a particular area that we focused on in the early neonatal period. But I suppose the first way to frame this is to recognize that CDH is a complex journey for the babies and children who are affected, but for their families as well. And for many of them now, of course, that starts in the fetal period with early prenatal diagnosis, and in some cases therapy. The neonatal period, even the first few breaths and minutes of life are a key period for people with CDH. But beyond that, beyond repair, beyond discharge from the neonatal unit, we know that it's a chronic condition, and there are many different teams and specialties who are really important in supporting and caring for affected people with CDH, even into adulthood now, we appreciate. So I suppose that's one of the important knowns and an important consideration when we're thinking about how we manage babies with CDH in terms of how that's setting them up in the optimal way for the best possible CDH journey. One of the other things that's known about CDH, of course, is the epidemiology of this condition. We recognize that it affects around 1 in 2.5 to 3,000 live-born babies, that the majority of cases are left-sided defects of the diaphragm, around 85%. A very small minority, less than 1%, are bilateral defects. We also recognize that it's a condition that doesn't come alone, that at least 20% of cases will have associated anomalies in other body systems. And one term for that may be CDH+. Some of the commonest associated anomalies are congenital heart disease, which around 20% of babies with CDH will have. We also have some understanding of the real impact of this condition in terms of morbidity and mortality. This is mortality data collected from a number of European centres up to 2021. And what it highlights in a number of ways are, firstly, that survival is somewhere between 60 to 80%, even in high-performing centres. So think about that. Up to 1 in 4, 1 in 5 babies with CDH sadly do not survive to go home. And I frame it in the context of babies because if you look at where the highest mortality is, you can see that it's actually very early in life. It's within the first day or within the first couple of days of life that much of this mortality happens. And that's a challenge for us, particularly us as neonatologists, to understand how we can impact that. So what I'd like to talk about over the next 40 minutes or so is the knowns and unknowns and priorities in terms of, first of all, the developmental aspects of CDH and what we understand around its etiology and don't understand, around the postnatal cardiorespiratory transition and early physiology, about how we can predict severity, particularly in the fetal period, and how useful that might be in guiding our management. And then talking about our therapeutic strategies, and particularly how they've been informed by our increasing knowns, our increasing understanding of this condition, particularly in the early neonatal period. And then, timing allowing, we'll think about what are the real future priorities for now and maybe for the next couple of decades. So let's start by thinking about the early embryology and fetal development in CDH. There's a hypothesis that was proposed a few decades ago, but that still stands, that this is a dual hit, that there is some form, and this is a fairly vague concept still, of a global embryopathy, potentially at its heart involving smooth muscle cell signaling that affects a number of body systems, not just the diaphragm, but also the lungs, the pulmonary vasculature, and increasingly also we recognize the heart in that. And then the second hit is this herniation of abdominal contents through the defect in the diaphragm in the fetus and the potential mechanical effect that they have. Now, when we think about those specific body systems, we've known for many years that there's pulmonary hypoplasia affecting both lungs. There's reduced numbers of airway branches, there's reduced number of alveoli for gas exchange. And alongside that, there's abnormalities of the pulmonary vasculature, particularly on the arterial side of the pulmonary circulation, with reduced number of arteriole branching, reduced numbers of alveolar capillaries, and thickening of the muscular and adventitial layers of those pulmonary arterioles, giving rise to a precapillary increase in pulmonary vascular resistance. And the heart, as I mentioned, is an area that there's also been recognition of, perhaps for a number of decades, but increasing significance attached to that now in fetal life. We know that there's relative hypoplasia, particularly of the left ventricle. It appears from ultrasound studies to be relatively narrow and elongated. And there are now cellular studies from animal models, specifically the nitrophen rat model of CDH, which appear to show abnormalities in myocardial energetics, particularly mitochondrial function, and also cellular structure, including capillary structure in the heart. Now, in terms of the etiology of these abnormalities, we recognize there's a genetic contribution, that's a known. With the advent of whole genome sequencing and its increasing application, that will detect abnormalities in over 50% of affected fetuses and infants with syndromic CDH. So those babies who have a CDH plus phenotype. In isolated CDH, whole genome sequencing will detect an abnormality in around 5% of cases. So that still leaves 95% of cases where we haven't identified a genomic variant. And therefore, a huge unknown is still what is the contribution to CDH etiology in those patients. Where there is a genetic variant, there's quite a lot of heterogeneity. We recognize that these may be larger chromosomal anomalies, including trisomies. These could be copper number variants, including some of the common ones that are listed there. Or they could be single gene variants that might be autosomal recessive, dominant, or X-linked. And there are some identifiable syndromes that those include, including Cornelia de Lange, Simpson-Golabi-Behmel syndrome, and Fryns syndrome. And interestingly, Fryns may be one where there may or may not be a clear genomic variant identified. So genetic heterogeneity and still uncertainty in the majority of isolated CDH around what the etiology is. By some really great work in the past 10, 15 years or so, we're also coming to understand the role of epigenetic regulators, microRNAs and circular RNAs. A lot of this work led by Richard Kaiser and colleagues in Manitoba, and increasingly by Augusto Zani and his group as well. And these are RNA, small RNA molecules that are themselves non-coding, but control and regulate the expression of other genes. And as the work expands, we're coming to understand how these microRNAs may have a role in pathogenesis of CDH, but can also be used as biomarkers and potential therapeutic targets, as nicely summarized in that figure by Flaminia Pinaloni. It's the microRNA 200A, 200B in particular that have been identified through animal models and then in human studies as well. But what we don't know yet is how we can truly use these microRNAs, circular RNAs as therapeutic modalities in CDH. Now, I'll come on to that later. Let's move on to think about postnatal cardiorespiratory physiology in CDH and what we understand about that. Now, what's been known for a long time, and you'll all be familiar with, is that pulmonary hypertension is a key component of postnatal life in CDH. And this is data from the CDH registry. The registry is based out of Texas. It was set up in the 90s, led by Kevin Lally and his wife Pam Lally, and now has really grown to incorporate data from anywhere between 60 to 90 centers throughout the world at any point in time. And it's such a valuable resource. And that allowed us to do analyses, including this one led by Dahlia Ferguson, where she looked at reported levels of pulmonary hypertension in the first 24 hours and their relationship with disease severity. And what you see here is that as you move from left to right, with increasing pulmonary hypertension severity, we see a significant trend of increasing mortality, but also in surviving infants, increasing oxygen discharge, days on the ventilator, later surgical repair. So this just reinforces something which has been known for a long time, is that the severity of pulmonary hypertension in the early neonatal period is an important independent predictor of disease severity. But the question is, why do these patients have pulmonary hypertension? And for a long time, the culprit that has really been focused on has been those abnormalities of the pulmonary vasculature in fetal life and their impact on disrupting the normal transition in the first minutes and hours of life. Of course, we expect and hope for normal pulmonary vasodilatation and a drop in pulmonary vascular resistance at birth. But in the setting of CDH, it's been hypothesized that those abnormalities, particularly on the pulmonary arterial side of the circulation, prevent that normal transition and lead to a persistent ongoing elevation of pulmonary vascular resistance and therefore pulmonary artery pressure, promoting right to left shunting within the heart and the ductal level, and giving rise to the hypoxemia that we typically see in these babies with CDH. And of course, one of the secondary consequences of that pulmonary hypertension in CDH, as in any other setting of elevated pulmonary artery pressure, is increased afterload in the right ventricle. And adaptive changes in the right ventricle that quickly become maladaptive. So as you see in this echocardiogram of a baby with severe CDH and pulmonary hypertension, the right ventricle is dilated, it's hypertrophied, and it's tachycardic. And these are all responses of the right ventricle to try and overcome that increased resistance and afterload. But they're maladaptive because they lead to an increased oxygen demand within that ventricle at the same time as there is a reduced gradient for coronary perfusion because of increased right ventricular intraluminal pressure. And at the same time, tachycardia, which will also shorten the time for diastolic filling and diastolic coronary perfusion. And what we see, therefore, is a transition to a failing right ventricle, reduced right ventricular output, and uncoupling of the right ventricle function from the pulmonary circulation. And when we've studied the right ventricle in these patients, what we particularly see is diastolic dysfunction, both driven by that tachycardia, but also by the reduced compliance of that hypertrophic myocardium and a failure of early diastolic filling in these ventricles. And you also see diastolic dysfunction in other pulmonary hypertension states, in children and in adults. But here we see it in CDH. And it's interesting, it took me a number of years to move away from just looking at that failing right ventricle and to also actually realize something that other astute clinicians had realized before, which is that there's also the potential for severe left ventricular dysfunction in CDH. And you see it here, particularly in the apical view in the top left here and the cross-sectional view through the ventricle in the bottom left. And these are just 2D loops where I'm asking you just to subjectively look at this left ventricle, but even without any quantitative analysis, we can see here really severe LV dysfunction. And what we've come to understand is the phenotype of left ventricular dysfunction, where we see pulmonary hypertension, and that's represented by right to left shunting in the duct in the top right image there. But also, interestingly, because of reduced left ventricular output and right to left ductal shunting, these babies very early on will have reversed flow in the aortic arch, retrograde flow in the aortic arch. And we recognize that this left ventricular dysfunction can often be disproportionate to right ventricular dysfunction or coexist with it. And it's an important mechanism of post-capillary pulmonary hypertension because the dysfunction in this left ventricle is associated with an increase in left atrial pressure and therefore pulmonary venous pressure, and therefore this back pressure in the pulmonary circulation, giving rise to elevated pulmonary artery pressure, but also potentially to pulmonary edema through the mechanism of increased pulmonary venous pressure. And there are a number of possible mechanisms that we hypothesize that might give rise to this LV dysfunction. In some ways, it's still unknown exactly what the cause is, but we think that potentially that developmental hypoplasia of the LV is a contributing factor, combined with the acute increase in afterload in the left ventricle at birth as the placenta is removed from the circulation, and also potentially those cellular abnormalities that we've had an early indication may exist in the CDH myocardium. And of course, it's a negative feedback loop with reduced cardiac output driving hypoxia and acidosis in these patients that will contribute to worsening myocardial function. And when we look at cohort studies of CDH patients from our own center, but also from the great work of Gabrielle Altit and Shazia Bombal a number of years ago in Stanford, and more recently the team in CHOP as well, the incidence of early LV dysfunction is really high, up to 50% or more of patients with CDH, including cases with mild CDH. And this schematic is really just to frame the contribution of that early LV dysfunction in the pathophysiological picture of CDH and the clinical phenotype that we see. So as I described, this early LV dysfunction can give rise to this pulmonary venous hypertension, and an important mechanism of the right to left shunting and the RV dysfunction that we see in this pulmonary hypertension state in CDH that will contribute to hypoxemia and hypercarbia because of reduced pulmonary blood flow. But at the same time, because of reduced left ventricular output and reduced systemic blood flow, that gives rise to the hypotension and the metabolic acidosis that we see in these patients. And we've continued to explore this and tried to understand not just the systolic dysfunction in these patients, but also the diastolic dysfunction. And this is a nice recent investigation by Julia Cantone within our group, using a number of different parameters to try and get insights into left ventricular diastolic function, including using this modality of left atrial strain. And what Julia was able to observe was that left atrial strain in patients with CDH correlated with measures of pulmonary artery pressure, including TR, but also with measures of gas exchange, and was associated with survival in these patients. So building evidence of the importance of early left ventricular diastolic dysfunction in the clinical picture in these patients. And what we've also come to understand is that there's a lot of variability in this, variability between patients, but also within patients. And they can express different phenotypes, which range from the patient who has preserved ventricular function to the patient who may have more of a right ventricular dilatation dysfunction phenotype. And with preserved LV function, that's the one second from the left represented here. And they may be ones who have more of a pulmonary arterial hypertension. Interestingly, these are the ones that are more likely to have a right to left shunt at atrial level, and a right to left shunt at ductal level. And then the third image along from the left here is representing a patient who has more of that LV dysfunction phenotype with pulmonary venous hypertension. And here we may more be inclined to see a left to right shunt at atrial level, but a right to left shunt at ductal level because of the elevated pulmonary artery pressure. Those ones actually, that pure LV dysfunction phenotype, are actually quite rare, probably less than 10% of cases. But more common is a biventricular dysfunction phenotype, as you see on the right-hand side, where we have severe LV dysfunction and RV dysfunction, probably a mixed phenotype of pulmonary hypertension with pulmonary venous and arterial components. And again, we might see left to right shunting or bidirectional shunting at atrial level and right to left at ductal level in these patients. Now, what's the clinical significance of this? Well, that's something we were again able to explore within the CDH registry. And this is data from over 1,000 babies in the registry, where we looked at the relationship between cardiac function phenotype in the first 24 hours of life and survival in the first 100 days. And what you see here is that survival was highest for those patients with normal ventricular function and progressively lower in those patients with right ventricular dysfunction alone, left ventricular dysfunction alone, and then worst in those patients who had biventricular dysfunction phenotypes. And in the analysis in this cohort, we were able to observe that, left ventricular dysfunction was independently associated with adverse outcome mortality in ECMO in this patient. And so it's really helped us to understand the importance of ventricular dysfunction as a target for improving outcomes in CDH and as a mediator of disease severity. Now, the timing of cardiac dysfunction in the early transitional period is also something that's been of interest. And this is data from the group in Denver, nicely graphically illustrated by Satyan. And what it shows, is, if you look at the bottom graph here, is that the proportion of patients with right and left ventricular dysfunction can be very high in the first days of life, particularly in the first hours of life. But what we see is that left ventricular dysfunction tends to resolve more quickly, usually within the first 72 hours, whereas right ventricular dysfunction may persist. And that's likely reflecting the fact that that pulmonary arterial hypertension component persists for longer in CDH and takes longer to resolve. And this is another attempt to try and represent it graphically in a recent review with Gabrielle and Annie Laplante in Montreal, and Florian, who's a colleague who works in a high-volume CDH center in Mannheim in Germany. And what we tried to illustrate here were the mechanisms whereby those developmental abnormalities that we understand in the fetus, particularly pulmonary arterial dysplasia, LV hyperplasia, predispose the patient at birth to this disrupted transition with early left ventricular dysfunction and pulmonary venous hypertension, but that's a relatively transient phenomenon, and that we thereafter may see ongoing pulmonary arterial hypertension with ongoing RV dysfunction. But there's a clinical phenotype, hypoxia, hypercarbia, metabolic acidosis, hypotension. It persists, but has those different mechanistic contributions during that period. But of course, the challenge is that in individual babies, each will have a slight variation on that transition. Some may have more LV dysfunction, some may have less, some may have more severe pulmonary arterial hypertension, some may have less. So how can we use that understanding as it stands to think about the clinical management of these patients? And let's start by thinking about predicting the severity in the fetal period. This nice figure by the group of Abergral and colleagues is an attempt to kind of summarize what we know about the fetal assessment of fetuses with CDH. And it highlights two established approaches to assessment of these patients. First of all, on the top left, our ability to perform ultrasound to assess for other associated anomalies and to perform genetic analysis from amniocentesis, including increasingly the use of whole genome sequencing in these patients. In the top right, it highlights established measures of pulmonary hypoplasia, in particular the use of ultrasound to obtain an observed to expected lung-head ratio, which is a very widely established and clinically utilized predictor of severity in these patients, particularly when combined with liver position and with other parameters, including stomach position. And alongside that, MRI is now an established measure of fetal lung volume and is also expressed as an observed to expected ratio. And that's something that we would routinely perform in our center with our help of our radiology colleagues. And it has good agreement with ultrasound measures, but potentially a degree of superiority, and also is combined with liver position. What is more of an unknown is the ability of prenatal assessment to help us predict postnatal pulmonary hypertension and cardiac dysfunction. And there are a number of parameters that you might think potentially could be used for that, including ones that look at flow within the pulmonary artery, pulmonary circulation within CDH, and also trying to look at measures of cardiac dimensions and function. But I would argue that actually that's still an unknown. It's still something where there has been variability in the observational studies to date in terms of the predictive ability, particularly of cardiac dimensions, to predict postnatal cardiac dysfunction and outcomes. So an important area for future investigation. And I just highlight this variation between prenatal assessment and measures of severity and postnatal cardiac function in particular. The echocardiogram on the left-hand side is of a patient that we encountered relatively recently who had an observed to expected lung-head ratio of 44% that actually puts them in the moderate category. But as you see, this patient had severe cardiac dysfunction from very early on. This echo was from 30 minutes of age. That left ventricle, as you can see, and the right ventricle free walls are hardly moving. And this patient had profound low flow state. And that was relatively unpredicted by their fetal parameter. And the data on the right-hand side is from another analysis in the registry led by Dui Dao, where he looked at patients with so-called low-risk CDH, the ones who had smaller defects identified at the point of surgery, so what we might call A and B defects. And interestingly, a number of these patients had poor outcomes and didn't survive. And when you look at the factors associated with non-survival, left ventricular dysfunction and right ventricular dysfunction and pulmonary hypertension were all associated. And indeed, on multivariate analysis, left ventricular dysfunction was an independent predictor of adverse outcome. So it shows that even in cases that appear to be mild CDH, the cardiac dysfunction can be disproportionate and really importantly so in these patients. And our understanding of why that is and how to predict it and really how to manage it is still quite limited. So let's think about therapeutic strategies and let's start thinking about prenatal strategies. this is a really nice article, a recent publication, and with this figure that summarizes some of the potential approaches that can be taken to mitigate and to manage CDH from the fetal period. As you can see, there are a number of potential candidates. The only treatment here that is an established clinical treatment is the fetal procedure, fetal endoluminal tracheal occlusion. The others at the moment remain either candidates or in the early stages of preclinical exploration. I'll just take a moment to talk about fetal, because I think in one way, what it highlights is that CDH, perhaps with only in comparison to the work done in the management of extreme prematurity, represents one of the areas of greatest innovation in neonatology. And this treatment certainly highlights that. As you'll know, this treatment involves placing, using fetoscopy, a balloon within the trachea, typically within the mid-20s gestation of life, with the intention of plugging the trachea and providing an ongoing intraluminal pressure and pressure within the airways and the alveoli to promote lung growth. And this is a treatment that was proposed many decades ago, and the feasibility was demonstrated at that point, but really was only subjected to RCT assessment thanks to the phenomenal work of Jan Preston colleagues. And they reported the Total trials a few years ago, which showed that certainly in the severe group of CDH patients who were eligible for this therapy, that it appeared to be associated with improved outcomes. It's also associated with risks, including in particular a higher risk of preterm birth in CDH and a preterm rupture of membranes. And in the context at which it's used in the Total trial, the balloon is typically removed within the mid-30 weeks gestation, and that itself is a procedure that predisposes to those increased risks, particularly preterm birth. One of the ongoing innovations that attempts to address that secondary risk is the development of smart balloons, which can be deflated without the need for a second fetoscopy to remove them. And these smart balloons actually deflate when exposed to a strong magnetic field. So actually just taking the mother around an MRI scanner is sufficient to get them to deflate. And the group, again, of Jan and colleagues are going to be reporting their outcomes from studies of using the smart balloon recently. And we heard a little bit of that already at the CDH International Symposium a few weeks ago. And that's an exciting development that potentially can address some of the risks of balloon use in CDH. Despite the demonstrated benefits of this technique, one of the real challenges is actually early diagnosis of patients and the practical aspects of getting them to a fetal center for treatment. And therefore, unfortunately, it's still only a treatment that is available to a minority of cases. As I mentioned, there is some real interest in other approaches to fetal therapies in CDH, and indeed combining those with fetal itself. And the group of Augusto Zani are really exploring the potential of these microRNAs and their carrier particles, which are extracellular vesicles. And these can be obtained from amniotic fluid and potentially administered through the tracheal route. And in animal studies, there's some really promising data to suggest that this can mitigate the impact of CDH, both on airway development and on pulmonary vascular development. So an interesting area of future investigation. There are also studies that have investigated the role of pulmonary arterial modulating therapies, including sildenafil, prostacyclins, including treprostinil, and endothelin antagonists, including bosentan, in fetal models of CDH. And they also show promise in potentially mitigating the adverse effects of pulmonary vascular development in CDH. However, one of the challenges of translational studies of those types of agents has been the adverse effects that have been seen of these agents in other fetal studies, including, you may be aware, the Strider trial that was conducted a number of years ago that explored the use of sildenafil in IUGR fetuses. And unfortunately, one of the signals in that study was increased risk of pulmonary hypertension, and in some cases, non-survivable pulmonary hypertension in fetuses who were exposed to fetal sildenafil. And that the consequence of those studies are that it really impacted clinical translational studies of antenatal sildenafil in CDH. And I think there's still a strong legacy of that in other fetal studies of pulmonary modulating agents in CDH. But we'll have to see in the future whether there are ways to mitigate those. Let's move on to think about therapeutic strategies in the delivery room and in the early neonatal period where we might be able to have an impact on these babies and frame it in the context of what we do understand around the pathophysiology in these babies. One area of interest has been around cord management, and this is a nice illustration again by Satyan to summarize one of the initial feasibility studies of an approach of physiological based or intact cord resuscitation in CDH. And this data by the group by Lefebvre and colleagues demonstrated that intact cord resuscitation was feasible and was associated with potentially improved signals of reduced arterial pressures of CO2 and lactate at 30 minutes, improved blood pressure over the first 12 hours of life in CDH patients. And there are other studies that have supported this work, including animal studies by the group at Monash, led by Stuart Hooper and colleagues, and also some initial early clinical work by the group in CHOP. And that has been important work that fed into two RCTs of physiological-based cord clamping in CDH. One is the PINK study led by Philip de Koning out of Rotterdam that has actually now recruited all of their cases and is just in preparation for publication. And the second is the CHOP study, which is a multi-center study, the CHIC study, of course, which is the multi-center study in France. And that one is also close to finishing recruitment and reporting their outcomes. So we're looking forward to seeing what the results of those studies will be. The primary outcome in the PINK study is pulmonary hypertension at 24 hours, and in the CHIC study is APGAR scores. So those, I suppose, reflect some of the challenges of identifying feasible outcome measures in CDH, but we hope they're still going to give us some guidance on how best to manage the cord in these patients. Moving on from the delivery room, what about our early neonatal management? And that's been a focus of interest for our group and others. And if we think about what historically has been the focus in managed CDH patients, it's targeted at early pulmonary hypertension. And we've thrown a lot of pulmonary vasodilators at these patients, including nitric oxide. But over time, we've come to understand that actually that may not be a good approach. And this is, again, a registry analysis led by Carla No, where she reported that the use of nitric oxide in CDH patients was independently associated in 3 different models, which you see represented here, with adverse outcomes, with mortality and ECMO use. And that is really quite a stark and a finding that stopped us in our tracks. Here's a treatment that we've been giving to these patients with the intention of treating their pulmonary hypertension and improving outcomes, but that actually may have been doing them harm. So why might that be? What do we understand? What's the known that we might have around that now? And how can we better use medications in these early days of or hours of life that might actually improve outcomes for these patients? With our understanding of the cardiac transition in these patients and the different cardiac dysfunction phenotypes that I mentioned to you, we've started to have a more targeted approach to management of these patients. And that's focused less on the pulmonary vasculature and more on supporting cardiac function, particularly LV dysfunction when it's present. And I'm sorry, the fine print on this may be quite small on your screens. I won't go through all of it, but it's really just to highlight that our approach has been one of early echocardiography combined with that understanding of that known knowledge of what may happen in these patients and using that to guide our management. So if we see LV dysfunction in these patients, our approach is more to to target inotropic support for them and to not rush in with pulmonary vasodilators, because actually we think that may make things worse. It's like trying to turn on the taps upstream when the blockage is downstream. If, however, left ventricular function is preserved or is improved, but we've got ongoing evidence of precapillary pulmonary hypertension, that's when we're more likely to target with pulmonary vasodilators. And interestingly, that seems to be when we're more likely to see a response to pulmonary vasodilators as well. And also that understanding that cardiac dysfunction, in particular left ventricular dysfunction, is an important mechanism of impaired gas exchange in these patients, so hypoxia and hypercarbia, has led us to be less aggressive with our ventilation and not to start to turn the ventilator pressures up and to use higher pressures early on. And personally, I think that that's helping us to minimize lung injury in these patients early on, and also to minimize the cardiorespiratory interactions and the potential for high pressures to exacerbate pulmonary hypertension. Let me talk you through a case to try and describe this approach. So this is a baby who was born at 38 weeks gestation, antenatally diagnosed left side CDH, who was in the severe category with observed expected lung head ratio of only 24% and liver up. And they fit our clinical phenotype in the first hours of birth. They're hypoxic, they're hypercarbic, they have a significant metabolic acidosis, and they're hypertensive. And when we perform an echo in this patient, what we see subjectively, but what we're also able to demonstrate objectively with measures of right and left ventricular function, is a severe biventricular dysfunction phenotype with significantly reduced right, but also importantly, left ventricular dysfunction. I've reported that the global longitudinal strain in this patient, as well as the circumferential strain in the short axis view, and the normal value here should be somewhere in the mid-teens, and you see the left ventricle longitudinal strain only -7, circumferential strain only -6. And this patient has severe pulmonary hypertension with a widely patent duct and predominantly right to left shunt. And they also interestingly have that phenotype of reversed flow in the aortic arch. And it's that orange flow that you see in the bottom right panel. Now, interestingly, the flow in the aortic arch is retrograde flow is going all the way around, almost to the origin of the right innominate artery. So you can imagine that when we measure a preductal saturation in this patient, it's actually deoxygenated blood that's going across the duct all the way back around the arch and up to the right arm. And that's really an important consideration when we're thinking about what is impacting oxygenation in this patient. So this patient has a severe LV dysfunction phenotype. Yes, there's RV dysfunction as well, but that LV dysfunction is certainly what jumps out to me and that I'm going to target first. So our strategy here is to support LV dysfunction. It's with inotropic support. In our center, we like to use low dose epinephrine, adrenaline, and then as blood pressure improves to feed in milrinone as well. We avoid pulmonary vasodilators. I'll come back to that in a second. And because we recognize that this is cardiogenic cause of hypoxia and hypercarbia, we keep a low pressure ventilation strategy in this patient. And we have ECMO potentially available if medical treatment is not working. I'm going to borrow an analogy that I first heard from Satyan, which is if the left ventricle here is a blocked toilet and the toilet is not emptying, if we give a pulmonary vasodilator here, like nitric, it's like flushing more water into that blocked toilet. Instead, what we need to do is to give something that will unblock the toilet, in this case, thyme and an inotrope. And that's what we did in this case. And within a day or so, we see very significant improvement in left ventricular dysfunction. So this really reinforces that LV dysfunction, although it can be very severe and life-threatening, can improve very quickly with the right support. However, on day 3, despite improvement of LV dysfunction, this patient still has a degree of RV dysfunction and RV dilatation and a degree of hypoxemia with a high inspired oxygen, even though their saturations have improved. So at this point, with ongoing pulmonary hypertension demonstrated with a significant ongoing right to left contribution of ductal shunting, we say that the phenotype has changed. And this is now more phenotype of precapillary pulmonary hypertension that persists with ongoing right ventricular dysfunction. And our approach here now is to think about pulmonary vasodilatation, optimizing our broader treatment strategy that will optimize pulmonary vascular resistance. So sedation, acid base, ventilation. and if need be, also directly supporting the right ventricle and supporting systemic vascular resistance to optimize coronary blood flow. So what we did was we introduced nitric oxide at this point. We got a partial response to that. So we then also started to feed in intravenous sildenafil. That's a second-line pulmonary vasodilator of choice. And we used a little bit of norepinephrine, noradrenaline, just to support the systemic vascular resistance. And within 48 hours, what we see is an improvement in right ventricular function, a less dilated RV, and improved oxygenation. And indeed, the ductal shunt had reversed, and we were happy to let the duct actually close at this point. We were also objectively able to say to our surgical colleagues that this patient's hemodynamic status has improved and optimized, albeit on a combination of low-dose inotropes and pulmonary vasodilators, but that targeted therapy has optimized cardiac function and pulmonary hypertension. And we were able to say, we think this patient is therefore ready for repair. And she went on to have a repair of a large type D defect. The surgical team inserted a post-pyloric feeding tube at the time of repair. And we believe that's an important contributor to minimizing postnatal, post-repair reflux and pulmonary hypertension. And as you see, she went on to have good post-operative course and discharge home at 5 weeks of age. At 3.5 months of age after extubation at 5 weeks. And what this really illustrates is taking this known understanding of the pathophysiology of CDH that's accumulated through, I would say, observational study over the past few decades, and applying this targeted phenotype-driven approach to management, which responds to the changing physiology of the patient. So as illustrated here, if there is severe LV dysfunction, we're targeting that with inotropic support, but as that transitions more to improved LV function and ongoing precapillary pulmonary hypertension, then feeding a pulmonary vasodilatory approach. And just as an aside, we also think about the management of the duct. And if the duct is closing and there's evidence of ongoing pulmonary hypertension with right to left ductal shunt and RV distension or LV dysfunction, then those are the situations where we target the use of prostaglandin to keep the duct open. There's also potentially the direct pulmonary vasodilating effect of prostaglandin in this situation. And one of the fellows in our department, Dana Levenkov, has done some really nice analysis to demonstrate the impact of this targeted approach to ductal management in CDH. And hopefully we can share that with you in published form soon. What this case also illustrates is this use of the hemodynamic assessment of these patients and the serial evaluation of the hemodynamics as an additional component of guiding the timing of surgical management in these patients. And this was nicely described in this recent paper led by Jack Wren out of Iowa with Patrick McNamara. And what this schematic represents is the combination of clinical parameters with blood gas indicators and most recently, the addition of echocardiographic assessment of cardiac function and pulmonary artery pressure to help make objective decisions about the timing of surgery in these patients. And ideally, what we're aiming for is optimization in terms of normalization of cardiac function and resolution of pulmonary hypertension, or as Jack described here, certainly pulmonary artery pressure is dropping below systemic to be able to say the patient is now optimized for theatre. But as we know, in many cases, particularly more severe cases of CDH, they won't get to that point. And instead, what we need to be able to say is that this patient has reached a point of stability with stable cardiac function, optimized as best we can, resolution of LV dysfunction, hopefully, and stabilization of pulmonary hypertension, if not resolution. And at that point, being able to say to our surgical anesthetic colleagues, this is as good as this patient is going to get. Now is the time for surgery. And interestingly, I won't share the data here in the interest of time, but when we've looked at the relation of timing of surgery to cardiac function phenotype in CDH, you won't be surprised to hear that it's the patients with a more severe phenotype with biventricular dysfunction who tend to, following this approach, have slightly later repair, typically towards the end of the first week of life, whereas those with normal cardiac function or more mild transient right ventricular dysfunction who have earlier repair. But it's helping us to add objectivity around the timing of repair in CDH. I've showed you one case of CDH and a kind of application of this hemodynamic-driven approach based on our understanding of pathophysiology. But can we translate that into greater evidence of benefit of this approach? And what I really feel is emerging now is evidence from a number of centers that this type of approach is having an impact. And I'll just show you data from our center and then some data from some other centers. So we just very recently analyzed two different eras of management in our center, an era up to 2021, and then more recently 2022 to the beginning of this year. And this is some data showing changes in our management approach based on our increasing understanding of that pathophysiology of early CDH. And what you see in the top left is, first of all, that we're performing echocardiograms even earlier because we recognize that LV dysfunction may be present very early from birth, and we want to try and identify that phenotype, and if it's present, use it to guide our management. We've moved away from using dopamine in the top right-hand corner, and I think that's something that's being seen internationally as we've come to realize that actually dopamine is not a good agent in this setting. It's likely to drive up pulmonary vascular resistance and also drive up heart rate with all the adverse effects that that brings. It may also have that adverse effect of increasing afterload and a failing left ventricle. In the bottom left, you see that we've actually changed our use of nitric oxide. We're not giving it to everybody straight away. Instead, we're deferring its use to later, typically towards the end of the first day and into the second day of life, once we're seeing resolution of early left ventricular dysfunction. So we're saving our pulmonary vasodilators until we've seen that change in phenotype from post-capillary pulmonary venous hypertension to pre-capillary pulmonary arterial hypertension. And as I mentioned, one of the other significant changes in our practice has been the use of early post-pyloric feeding with the help of our surgeons inserting these tubes soon at the time of surgery or through interventional radiology early after a surgical repair. And the impact in our center has been, firstly, on the left-hand side here, a very significant change in our use of ECMO in this population. We used to use ECMO in about 30% of our CDHs, and actually between 2022 and 2025, we didn't use ECMO at all. We did have one case that went on ECMO at the beginning of this year, but you can see very significant change in ECMO use with this more hemodynamic-guided medical management of patients. And associated with that, we see a trend in our survival as well. And we hope that that's a signal that we're going to continue to see. Now, as I mentioned, there are other centers who are similarly applying what I would call this pathophysiology-based approach and seeing changes in their management and in their outcomes as they do that between eras. I call this the eras data. It's a bit like eras. I put the Taylor Swift eras tour up there to it coincides with that kind of period. So here's data from Pittsburgh, from a group in Israel, from Vancouver, and from Baltimore, where they have their own center-specific variations on this, but at their core, what they're doing is moving towards more gentle ventilation, low-pressure strategies, both on conventional and high-frequency ventilation modes, because they understand this is not a ventilation problem, this is a cardiovascular problem. They're using targeted echocardiography to defer nitric oxide use if there's LV dysfunction, but also to have more of a inotropy-focused approach to management, where they're treating cardiac dysfunction rather than rushing in with pulmonary vasodilators. And you see on the right-hand column here, variable improvements in mortality and ECMO use, and interestingly, in reduced nitric oxide use in these groups. And one of the other groups who has also, I would say, really been able to demonstrate the benefits of this approach are the group of Brad Yoder and Michelle Yang in Iowa. And they introduced changes in their practice from 2016 onwards and have consistently and sustainably shown improvements in survival and reduced ECMO use. And again, it's this less is more approach. They use gentle ventilation, lower pressures. They recognize that they need to allow time for these babies to transition, for the heart function to improve. They tolerate lower saturations, a degree of permissive hypoxia and hypotension as the heart is going through that transition. And they use less aggressive approaches to pulmonary vasodilatation and inotropic support. And really, this approach is nicely summarized by this recent review by Anna Foth, David Tingay, Florian Kipfmuller, where they talk about this more gentle approach to cardiorespiratory management in CDH, using targeted hemodynamic approach, using gentler ventilation strategies, and combining that with serial functional echocardiographic assessment. And what they also highlight, and what is nicely highlighted in this recent review by Kelly Saint-Denis and Trish Prentice and colleagues, is also how we incorporate the family in the management of these babies, and actually as partners in their ongoing care. And that's really important in context of this as a chronic condition, a lifelong condition. And it also highlights, I suppose, really the importance of our partnership with families and wider neonatal practice. We certainly are involved patient associations in the UK, including CDH UK, in our research approaches, and we try to understand what's important to them. And I know in Australia, there's been a really strong engagement with CDH Australia and with patients and family associations. And through that, we're also helping to design programs that will support families, not just in the early period, in the prenatal and early neonatal period, but throughout life. The importance of multidisciplinary follow-up in CDH has been demonstrated in a number of centres for pediatric management of these patients, but there are now groups, including the group in Rotterdam of Lieke Kampfius and Hanneke Ischenstein, who are developing adult programs to support the transition from adolescence and teenage life into adult care for patients with CDH. Because as more severe patients with CDH are surviving, we're beginning to understand the ongoing morbidities that they encounter that affect both respiratory system and in particular growth, nutrition, and in fact potentially also cardiovascular function. That's still something that's a little bit unknown, but that we're actively studying at this point. So just to round off, what are the future priorities for investigation and care in CDH? Happily, there's been great work done in Australia to help answer that question, led by Tricia Prentice and Roberto Coletti and colleagues, and in conjunction with the Jane and Linda Alliance, where they went through a priority setting exercise. And here are the top 10 priorities that they came up with. And I've highlighted some of the ones that perhaps I've focused on discussion of today around the early transitional period and early management of the circulation and pulmonary hypertension in CDH. And those were certainly things that families and clinicians felt were important. But they also identified those long-term issues, particularly around your developmental outcomes, feeding, gut health, and long-term respiratory function. So really, this is an important publication to keep our minds focused on those areas and as future priorities. And in terms of how we do that and what care might look like in the next 20 years, that's something that we took a punt at trying to think about in this recent review with David McCulley, who's doing amazing work. David's a neonatologist, but he has a lab looking at exploring the impact of specific genomic variants in aspects of CDH and how they might impact on specific phenotypes in CDH. And in this kind of future-looking approach, we imagine the future where there will be early genomic and physiological phenotyping of fetuses, targeted therapies, including gene therapies and epigenetic treatments, where there will be early postnatal management that uses a combination of physiological therapies and early AI-guided management to really optimize therapeutic management in these patients, and that ultimately that transitions into what will hopefully be lifelong surveillance and optimization of care and self-management for these patients. So let's see how the future unfolds. We also just highlighted what we thought were the important infrastructure components that might help us get there, including ongoing, collaboration. And one of the things I love about CDH is really the highly collaborative nature of it. I've highlighted the work of fantastic colleagues and friends throughout the world who I've had the privilege of working with, and hopefully will continue to do so, but also how we can take inspiration from other research platform approaches and apply that to CDH. one of the things that always comes up when I meet families with CDH is they say, we'd never heard of this condition. And I think that highlights how in the wider context of society, we've actually got a job to do to help people understand the importance and significance of this rare condition. And hopefully that will help to drive resource to help us improve research and management here. So I'm going to stop there. I'm going to thank you all so much for listening and bearing with me. I know that was quite a canter through the knowns and unknowns and priorities for CDH, but I'm always happy to talk more. There's my email address if you'd like to get in touch. And I have to acknowledge many of the wonderful colleagues who can contribute to the work that we're involved with and the ongoing collaborations that we have. So thanks for listening and look forward to any questions that you might have.
Wow, Neil, that was an amazing sort of overview, which, we got you here, like, I think it was about 3, maybe 4 years ago, just talking about diaphragmatic hernia. And it was more like, come on, get this concept of this left ventricular dysfunction. But, today, the advances you've made by your collaborations and working with everybody in the field has absolutely shown off. You talked about the complex journey, which that was a really nice term. And then you highlighted diaphragmatic hernia and fetal development. There's various aspects to it. And then you specifically focused on the heart and the different phenotypes. What gives hypoxia? It's not just the right ventricle pulmonary hypertension, but there's different phenotypes in there. Diastolic dysfunction, left ventricular dysfunction came sort of forward. And you then explained how these different phenotypes had a clear impact on clinical outcomes and expectations. That was really, really wonderful data. And then you went to all these things, what we can do, antenatally, smart balloons, love that term, micro RNAs, and then, of course, delivery room sort of care, what we can do there, and the early NICU phase. And you highlighted, particularly in the early NICU phase, that early nitric oxide use should be reconsidered. We need to sort of look into that a little bit better and different, because it is about the timing of treatments and including the timing of surgery, which then that last paper you showed of your data, the differences in eras, that was just wonderful. The amount of progress, even though you say it's not significant, but it is significant. A change in mortality from 19% to 10% is very significant to the parents. So with this and all of this, let's see what the questions bring up. We'll go to a couple of questions here. What's the role of hydrocortisone in hemodynamic management of diaphragmatic hernia?
Yeah, great question. So we use hydrocortisone early in these patients. So when we have a patient who has significant ventricular dysfunction and hypotension associated with that, we will get in early with hydrocortisone. As you know, as in other contexts, hydrocortisone has those general tonic contributions supporting both improvements in, I think, systemic vascular resistance, but also potentially some direct effect on cardiac function. So yes, we use it early. I'd be interested in what other people's experience are, but if we're starting epinephrine, which we like to use in lower dose, then we'll get hydrocortisone started early. And we also like to wean it as soon as it's possible to do so. We are always conscious of the longer term effects of steroid exposure, both on myocardium and obviously more broadly systemically. So yes, good in the short term when we've got hemodynamic compromise, but then consider when you don't need it and wean it progressively, not too quickly, but wean it when it's not required.
All right. So Vinayak has a question about the foramen ovale. You talked about the two shunts, and different phenotypes, and some have a foramen ovale shunt, and it can be different direction. You have your PDA shunt. So that foramen ovale, how important is that?
Yeah,
Some of it is really tiny.
Great question. I think the foramen ovale continues to be like an area of interest in CDH and in other settings, and there's been a lot of interest in can we use it as a window into the cardiac function, as a quick way of knowing, is this a LV dysfunction phenotype with predominantly left to right dysfunction, or is it more of a right to left phenotype with right to left dysfunction? And personally, I think it's useful, but as with any echocardiographic assessment, no single parameter tells you the whole story, and there's a danger in just looking at one thing. So yes, I think as one window into dysfunctional phenotypes, it's useful, but I would say don't use it in isolation. Absolutely use it in the context of a broader assessment of cardiac function. So that's the first thing I'd say about the PFO. In terms of the specific question, I think it's a really interesting one. To what extent does the fetus, does the newborn have this potential benefit of the PFO of offloading that pressure-loaded left heart? And that dysfunctional left heart? And is it a problem if the PFO is restrictive? I think this is an unknown, and it's something for us to study. I was having exactly the same thought last week. I was at the EuroELSO, it's ECMO conference, and I was listening to all of these adult intensivists talk about how they need to vent the left ventricle in the setting of ECMO, because they get this phenotype of severe LV distension, in fact, so severe that you get aortic valve dysfunction and failure of opening of the aortic valve. And as a consequence of that, back pressure and pulmonary venous hypertension, and indeed stasis of blood in the left ventricle and aortic thrombosis. It's like a kind of extreme version of the dysfunction that we're seeing in these babies. And they have a number of strategies for venting the left ventricle, as you'll know. And it really got me thinking about how babies are lucky in having this natural vent. They have this patent foramen ovale. In most cases, that probably is having a contribution here, I think. And to your question, Vinny, I think maybe in a baby where there's a restrictive atrial septum in this context, it's a bit like having a restrictive atrial septum in hypoplastic left heart syndrome. It could be a contributing factor to a very severe phenotype. And unfortunately, as you described, to a baby deteriorating very quickly and having worse actual respiratory function in that context as well, because of severe pulmonary venous hypertension and pulmonary edema. So I think it's a great question, and probably one that we still need to answer. It's still an unknown.
Hey, can I ask you? You said earlier ultrasound helps. I have two questions about it. One, the guidelines say in the first 24 hours, but you probably go like, nah, that has to be. So how early does it have to be?
Yeah.
Two, you already mentioned the parameters you measured. Is cardiac POCUS enough for this disease?
Sure. Okay, great question. So first of all, when should we echo? Now, I've shown you really early echoes, and that's in the context of our center, where we're doing these echoes clinically because we want to know what's going on. We're going to use that as part of our wider clinical decision making. It's just one factor in that, but also because historically and continuously, we're interested in studying these patients. It's an observational investigation of them. But I wouldn't say that is an approach that has to be applied everywhere. I actually think what we've realized and learned in terms of our knowledge of what the potential phenotypes are and what that delayed transition looks like can be applied even in the absence of an early echocardiogram. And in fact, I would argue that's what the team in Iowa have applied. They've taken an understanding of the physiology and used that in their clinical approach. But actually, they recently published a paper where they said that delaying echo was actually better for them. Now, there's a lot of reasons for that. It's partly because echocardiograms in their population were predominantly performed by cardiologists. And without disparaging the cardiologists, we all are aware that might involve, let's say, someone who's training in cardiology, spending an hour or so doing a full structural scan on these patients, and potentially that may contribute to the destabilization of a very compromised patient already. So that may be why in their center, actually deferring echocardiogram appeared to be associated with improved outcome. When we're talking about echoes, we're talking about a quick functional echo that is just going to help us understand what, exclude major structural abnormalities, B, what's the functional phenotype here? So to your second question, Kurt, can that be done with cardiac POCUS, i.e. using limited functional assessment? That would be my interpretation of that, including subjective assessment and maybe a limited number of quantitative measures. Yes, I think it can, because in the cases that I showed you where we're seeing clinically significant dysfunction, it's grossly obvious. It's grossly obvious on subjective assessment and on those relatively straightforward quantitative parameters. One of the challenges that we've set ourselves in the past couple of years is actually to say, can we come up with standardized approaches to the assessment of these patients? Firstly, to define pulmonary hypertension and CDH, and secondly, to define cardiac dysfunction. And some of you may be aware, or may even be involved in the process that we went through, which was a Delphi process, which has taken us about 18 months. And that's been led by a couple of great colleagues who've worked with me on that, Rupa Hari Gopal in St. Louis and Sandy Young in Seattle, as well as Abhijit Bhattacharya in our department. And we just got to the point of those definitions, and we presented them at the CDH meeting a couple of months ago, and we'll hopefully have them published for you all to see. And what we've tried to do there with a group of international experts is say, what are practical things that everybody can use that will help them identify pulmonary hypertension and cardiac dysfunction in CDH, but also in this context of not as a one-off, but as a changing pathophysiology. So it's like serial assessment. So yeah, we'll be really interested in what everybody thinks about those and whether they're useful.
Yeah, it'd be awesome. So, but your first scan is sort of when the baby comes in, I'm assuming.
Yeah. Sorry. Yeah, I like to do it as soon as the baby has got to the unit and there's an opportunity to do it. So we usually get a chest X-ray, blood gas, confirm the tube position, and then usually while we're setting up for central lines, I'll have a quick look with a scanner if I can. Yeah.
Look, it's 7. One quick question from Cam. Can fetal echocardiography indices help predict left ventricular dysfunction? I think you mentioned something that was a bit variable.
Yeah, exactly. That's right. So great question. We were hopeful that they might. The signal is not absolutely there yet. So from the fetal studies that we have that have shown left ventricular hypoplasia, particularly reduced LV width, some identified a relationship with survival, but that relationship with cardiovascular phenotypes has not yet been demonstrated. And it's a challenge for all of us who are interested in the field to try and link up that fetal bit with the early postnatal bit. So work in progress.
Yeah, you need to fill up the left atrium to see how the heart is responding. And that's just not happening as a fetus. You need to be born first before the left atrium expands and what it does there. So I think that will be
totally. Yeah.
Look, Neil, thank you so much for getting up early. Thank you all for attending. We will be back, I think it'll be next week again with Ashraf Karat talking about septic shock. Neil, have a good day and love to hear from you with your next progress. Thank you so much.
Thanks very much, guys. Thank you, Kurt. Thank you, everyone.
Thank you.
Bye now.
Sure, let's start. Good afternoon, everyone, and welcome back to Australian Neonatal Lectures. My name is Tuba. I'm one of the neonatologists in Brisbane at Mater Mothers Hospital and also a researcher in Melbourne, and I will be hosting today's session. Thanks for joining us. We would like to begin by acknowledging the traditional custodians of the land on which we are each meeting today and pay our respect to elders past and present. A few housekeeping points before we start. Please keep your microphones muted and post any questions, any difficult question to our speaker comments in the chat during the presentation. We will try to address as many as possible in the end of the talk. And now I think it's my great pleasure to introduce you to today's speaker, Associate Professor Kurt de Waal. Actually, Kurt needs hardly an introduction. He is very well known to you as one of the main hosts in Australian neonatal lectures. Kurt works as a neonatal consultant in John Hunter Children's Hospital in Newcastle, and he is widely recognized and world-known for his expertise in neonatal hemodynamics and for his passion for bedside ultrasound. So Kurt today is going to talk us about intraventricular hemorrhage. As you all know, IVH is a critically important topic in our unit. We daily deal with IVH. We try to do our best to prevent it, but despite all the advances in neonatal care and neuroprotection bundles, IVH remains as a major contributor to the mortality and also poor neurodevelopmental outcomes for our preterm population. So today, Kurt is going to talk us about IVH and underlying pathophysiology of IVH, and also discuss potential strategies for prevention. Thanks, Kurt, for accepting this invitation. We are so excited to hear this talk. Now over to you.
Thanks, Tuba, and thanks for this introduction. And indeed, can we prevent? I think that's probably the main question we always have. IVH in our preterm infants. And I think when we start about talking about a disease, we need to know what it is, or a complication. And these are two slides, pathology slides of the typical sort of IVH we as neonatologists encounter. And when we look at IVH as sort of over time, particularly in preterm infants, we start to realize that almost all of them start in the germinal matrix. And there's a good reason for that. If you look at the germinal matrix from a fetal sort of developmental perspective, you can see from the left to the right of your image where the germinal matrix is in the top one in sort of deep purple, in the bottom one in brown. And then you can see that development over time, that it is actually really big before it starts to involute and get much, much smaller. And the reason for that is that the germinal matrix is carrying neural precursor cells. So the in sort of original primitive preplate subdivides, and then it creates those layers in the brain, which we are familiar with, certainly later in development. And these layers and these neural